Hi, my name is Bill Pienka. I'm a hand surgeon in Fort Worth, Texas, and I'm honored to be here to present the work that myself and my colleague Dr. David Wickman have done recently on Kienbock's disease. In 1977, Dr. Lichtman introduced the initial classification system for Kienbock's disease based on radiographic findings, and this has been modified several times since then to now include a treatment algorithm. The problem with Kienbock's disease, however, is that there are too many treatment options because there's many etiologies that have been proposed to lead to the development of Kienbock's disease. Here you can see just some of the proposed etiologies for Kienbock's disease, ranging from traumatic causes to anatomic variations, vascular conditions, as well as different coagulopathies and other miscellaneous conditions. And we're finding out that medications, genetics, and the role of osteoclasts may not only be etiologic factors, but may exacerbate the root cause or act as a catalyst for the development of lunate osteonecrosis. In addition to the numerous etiologic factors that have been proposed for Kienbock's disease, there's also been a multitude of treatment options which have been proposed for different stages of the disease. The numerous factors that contribute to the development of Kienbock's disease, as well as the numerous treatment options, can be confusing to the surgeon that is tasked with addressing this condition. The initial Lichtman classification system seen here is based on radiographic parameters seen on X-ray and MRI. Greg Bain and his team in Australia introduced an articular-based classification system based on the condition of the cartilage seen during wrist arthroscopy or on MRI. They subsequently modified this to include a treatment algorithm based on bypassing what they considered non-functional or involved articular surfaces. Rainier Schmidt and his German radiology colleagues introduced a classification system based on contrast-enhanced MRI, looking at uptake within the lunate to determine whether there was intact lunate perfusion, partial or complete osteonecrosis. What's really nice about these three classification systems in particular is that they pretend prognosis for these patients. And as such, we're able to make treatment recommendations and create a treatment algorithm to help guide surgeon decision-making for the treatment of Kienbock's disease. Once we put these three classifications and their prognoses next to each other, you can see it makes sense to combine these classification systems to create a much more nuanced and precise treatment algorithm. And that's exactly what we did in 2016. What you see here is the combined treatment algorithm that we published in the Journal of Hand Surgery in 2016. The problem with this, as you can see from this chart, is that this is not a very nuanced and certainly not an easy to interpret chart. In order to simplify the combined treatment algorithm, we came up with the key questions of Kienbock's disease. And these questions are as follows. What is the age of the patient? Second, what is the state of the lunate, and is the lunate affected in isolation? Third, what is the state of the wrist? Does the disease extend outside of the lunate? And other things that need to be considered are what are the patient's goals and what do they want, as well as what can the surgeon offer. As we take each key question individually, we have to start with what is the patient's age. And this is important because we know that young patients do well with non-operative treatment. In patients less than 15, non-operative treatment should be the mainstay for Kienbock's disease. We also know that patients that are older than 70 years old tend to do well with non-operative treatment, and their symptoms tend to improve with time despite radiographic progression. For patients that are between 21 and 69 years old, however, we suggest moving on to key question B and key question C. The second key question that we must ask ourselves is what is the state of the lunate, or is the lunate affected in isolation? And if it is, the patients will fall into one of these three categories, where the lunate is intact, compromised, or not reconstructible. Treatment strategies and treatment recommendations can be found here. If the disease extends outside the lunate, we move on to key question C. What is the state of the wrist overall? And here we have three subcategories based on the involved articular surfaces. In class C1, there's carpal collapse, but the articular surface of the distal radius is still viable. Class C2, there's non-viable or involved distal radius cartilage in either the lunate or scaphoid facet, but not both. And in class C3, there's advanced carpal arthritis, or what we call KDAC, Kienbock disease advanced collapse. The treatment recommendations seen here involve bypassing the involved articular surfaces. We recently published what we call the Unified Classification System of Kienbock's disease addressing the 3 key questions in the Journal of Hand Surgery. This table is taken from that publication, and you can see we've made treatment recommendations based on where patients fall into the unified classification system and their answers to the key questions. To summarize, don't be overwhelmed by the numerous treatment options or the complicated treatment algorithm here. Do a complete workup on all these patients to include X-ray, MRI with contrast, and evaluation of the cartilage either through arthroscopy, MRI, or direct visualization intraoperatively. Remember the key questions. What's the patient's age? What's the state of the lunate? And what's the state of the wrist? And don't memorize this treatment algorithm. Reference the article, save Table 5, and reference it when you have these patients to help guide your decision making. We thank you for the opportunity to present our work and be happy to answer any questions at my email seen on the screen.